live in person, but also virtually, broadcasting live. We're going to talk about refining the first strike against EGFR mutant advanced non-small cell lung cancer. We have an in-person audience, but also a pretty big virtual audience live streaming. So welcome everybody to this activity. It's my pleasure and privilege to be seated next to a colleague, Dr. Zosia Piotrowska from Massachusetts General Hospital in Boston, Massachusetts. We want to thank PeerView for providing this session and AstraZeneca for providing the educational grant for this symposium. There is a pre-event survey, which you'll see on your virtual player or links from the QR here at your table. Look out for additional polling during the presentation, and if you want to submit questions, we'll do our best to answer them as we go. Here's a QR code. You can scan this code from your personal device to ask us any questions that you might have. I will send all the tough ones to Zosia, and the softballs I'll take myself. On your mobile device, just open the camera app and take a picture of that QR code. And again, on your virtual platform, you'll see the link to questions there on your virtual player. You can also visit us at peerview.com/Lake Tahoe 24, where you can download a copy of this slide presentation and various practice aids available after this event, and join our discussions on social media too. Our goals for today: to augment your already existing knowledge on the evidence supporting the use of different frontline treatment options for advanced EGFR mutant non-small cell lung cancer, and to equip you with the skills for developing individualized first-line treatment plans with EGFR targeted therapies or combinations for patients with EGFR mutated advanced non-small cell lung cancer. And so our spotlight really is on EGFR mutant non-small cell lung cancer. By way of background, we know that non-small cell lung cancer is not one disease, it is a family of related diseases, each with different alterations underlying them, and each of the slices on that pie really represent a different biology, a different cancer and hopefully in the near future, different treatment. We do have different targeted, personalized therapies for various subsets of lung cancer. It guides our treatment decisions from the jump. Frontline therapy in advanced setting, but increasingly in early stage setting, not just to deliver targeted therapy, but also to avoid things like immunotherapy. Still, in order to leverage these changes to really deliver targeted therapy, we need to find the target when present, and certainly this is an area where we can improve. If we look at frontline setting, the use of biomarker tests, how often do we have those biomarkers available before we start frontline treatment? We want that number to be 100%. It is about 55%. And so certainly better than it was just a few years ago. 2018 to 2020, we saw that number was about 37%. Now we're at 55%, but I certainly think collectively we can do a lot better. These are data from the MyLung Consortium. These are patients with insurance, with physicians, oncologists plugged into our system. How many received molecular testing for advanced treatment prior to frontline therapy? If you look at EGFR, a fairly simple test, one we've known about for a very long time, we are at about 80% testing for EGFR, which means 1 in 5 is not being tested for EGFR. Many people then are delivering the wrong treatment for some patients. 80% is the best we've ever seen, but still not nearly good enough. About 75% for things like ALK and ROS1, and closer to 66% for RET. So 1 in 3 people not being tested for RET, and if we're missing some of these alterations, we're giving some people the wrong treatment. And so if we look at this data from Matt Smeltzer presented, the ISLAC Global Survey on Biomarker Testing, here we looked at sort of the global perception of biomarker testing. If you look there at the top right, about 67% say most of their patients are getting biomarker tested, which is better than before. In 2018, it was 40%. So a lot of improvements, the perception of the importance of testing, but in terms of delivering that testing, certainly a long way to go. The highest barriers there at the bottom left: cost, time, sample quality, access, and awareness. And I think all of us in some way can attribute some of the barriers to these, and we can certainly help to overcome them. Our focus today is on the frontline EGFR space, and for a long time this was a pretty simple discussion where really we had osimertinib as by far our best and brightest treatment, our standard of care, but recently we have several different combination therapies that have made these decisions a little more complex. I think it's good to have options, but how do we navigate these waters? That's going to be our focus for today. So we're going to have a candid conversation, some clinical consults. Would love to have some interaction here. How to interpret the evidence, looking at these different frontline options, and we'll start with a case. And so if you want to pull out your devices, we're going to have you vote on some of the treatment options. All the treatment options for all these cases are the same, and so we're interested in how you're going to approach these cases. This case, a 61-year-old female, no history of smoking, cough, dyspnea, fatigue, pretty standard symptoms. We do some imaging. We see a 3-centimeter left lower lobe lung mass, bulky mediastinal nodes, liver metastases, and bone metastases. The MRI shows we also have several sub-centimeter brain metastases. So pretty widespread disease, liver, bone, brain, node, and lung. The FNA shows a TTF1 positive adenocarcinoma, and we find an EGFR exon 21 L858R mutation, PD-L1 negative. Now they're here in your clinic with all of this information packaged for you to make our decision. What are you recommending today with liver, bone, brain metastases? Is it osimertinib monotherapy? Is it osimertinib plus chemotherapy, the FLAURA2 regimen? Is it amivantamab and lazertinib, our Mariposa regimen? Is it erlotinib and ramucirumab or bevacizumab, the relay regimen, or the Ramos regimen? Or is it carboplatin, pemetrexed, pembrolizumab, the Keynote 189, or not sure? If you want to key in your vote.
You're not going to tell us about P53?
We'll come to that in a little bit, Paul. Now these are fun because there's more than one right answer.
Yeah.
There's no clear sole right answer. It is formed by a lot of different clinical situations. But what are you choosing in your practice today?
A lot of times we do these CMEs and it's just one, we're looking for one right answer. I think here we're looking to see what is the spread of what people choose in this situation. So.
All right, let's take a look at how the room's feeling. We've got largest vote for osimertinib monotherapy, some votes for osimertinib chemo and amivantamab lazertinib. Some people not sure. This is both at home and in the room, and so we see a pretty wide spread. Excellent. All right, let's talk a little bit about some of the data here. What do we know about these regimens, Zosia?
Yeah, so let's review. I think, we've all seen this data before, but I think it's always worth reviewing again in the context of a patient. I think we are all having these discussions in the clinic. I just had one this week. I think, it's a lot of data to kind of contextualize and to discuss with patients, but it's really important to do so. So, really the three regimens to talk about, as you saw in the question answers, are the osimertinib monotherapy, FLORA, OC plus chemotherapy from FLORA 2, and then amivantamab and lazertinib from the Mariposa study. So first looking at the oldest of these trials, the FLORA study, of course you're all familiar, this came out a number of years ago now in 2018, and it really clearly showed that osimertinib was superior to the first generation EGFR inhibitors, erlotinib and gefitinib, in terms of really all of the metrics that were used in the study. It improved median progression-free survival, it improved overall survival, as you can see in the Kaplan-Meier curve here, with a median OS of about 39 months. We saw improved intracranial penetration compared to the first generation TKIs, and we saw a fairly good safety profile. Of course, not perfect. We still see rash, diarrhea, paronychia here. Rarely we can see QT prolongation, and then we'll always have to be mindful of ILD. But generally speaking, I think this is a well-tolerated regimen. A lot of times we start patients on treatment, see them back a couple of weeks later, and if they're doing well, they're only coming to clinic every few months for scans and visits. So that really established our old kind of first-line standard of care, and for many years the conversation was easy. There was really only one right answer to that question we just asked, and the visit with those newly diagnosed patients was relatively straightforward. You have EGFR, take this pill, we'll see you back in a couple weeks. But now things have gotten more complicated, I think in a positive way, because we now have evidence. Ooh, maybe not easy. Should I keep going?
Yeah.
Okay. So, we now have combination strategies, which we know can improve progression-free survival, both in FLORA 2 and Mariposa, but come at the cost of more frequent clinic visits, toxicities, and other things that have to be weighed here. So looking first at the data from FLORA 2, again, you're all familiar with this primary endpoint here of progression-free survival, which in this study was newly diagnosed patients, classical EGFR mutations, and they were randomized to either osimertinib monotherapy or osimertinib with platinum pemetrexed chemotherapy, followed by pemetrexed maintenance. And what we saw here in this primary endpoint of PFS by investigator assessment was an improvement in PFS of about 8 months, 16.7 to 25.5 months. Hazard ratio here was 0.62. We saw, and we'll show you a few of these subgroups, that this PFS benefit was really maintained across all of the different subgroups that were evaluated, including patients with CNS metastases and others. The overall survival data from both of these studies is not yet mature. We recently had the presentation of the second interim analysis this spring, which trends towards positive with a hazard ratio of 0.75, but these are not yet fully mature data, so we'll have to wait longer to get that full overall survival result. And then, of course, we're all familiar with the toxicities that chemotherapy brings to the table in terms of both myelosuppression, increased rates of nausea, fatigue, coupled with the toxicities of osimertinib. But overall, I think, chemotherapy toxicities are something we're generally familiar with and comfortable managing, and patients can do fairly well with this regimen. Looking at a few different subgroups, I think there's been a lot of breakdown of this data by all different subgroups, and the main take home here is that no matter how you slice these data, patients benefit from OC plus chemotherapy. We see that in this analysis here, looking at patients with a higher disease burden, here assessed as 3 or more sites of metastatic disease. Again, here you can see that there is benefit in both groups, whether they have 3 or more or less than 3 sites of metastatic disease. Perhaps a slightly better hazard ratio of 0.57 in those patients with more disease burden, but overall you'll see that patients with these unfavorable risk factors across the board have slightly worse outcomes, as you might expect. So, I think OC chemo helpful in this subgroup. Also, similarly, we see benefit whether patients have liver metastases or not, whether patients have bone metastases or not. And if we look at these curves and try to identify places where there might be particular separation of these curves, where chemotherapy may particularly add benefit, perhaps in that subgroup with bone metastases, you can see the hazard ratio was 0.56, whereas those without 0.70. We have to be cautious about those data. These are small numbers, post hoc analyses. So I don't think these are definitive definitive, but certainly give us a sense that these patients may have particular benefit with the addition of chemotherapy. I think one of the analyses that's been maybe among the more compelling is patients with baseline CNS metastases, and that was about 40% of patients in this study. I think relatively consistent with my clinical practice for seeing patients with EGFR. And if we look at patients with baseline CNS metastases at study entry, you can see that these patients had an even more meaningful improvement in that median PFS, 13.8 versus 24.9, and that translated to a hazard ratio of 0.47, whereas those without CNS metastases, again, still benefit, but the magnitude of benefit was a little bit lower, and you can see that the hazard ratio crossed 1 in this subgroup. So I think some hint that CNS metastases may be a particular biomarker here. One of the questions is, why might that be? We know osimertinib has intracranial activity. We saw that in FLORA. But I think pretty striking when you look at these waterfall plots to see that, adding chemotherapy to osimertinib, if you look at the response rates along the bottom here, they're not actually numerically that different, but if you look at the waterfall plot, you can clearly see that there are deeper responses and significantly more patients having complete responses, and that does seem to translate to long-term benefit for these patients. So I think these data, when I'm thinking about my clinical practice, are an important kind of subgroup of this study. Moving then next to Mariposa, of course, this was a first-line study of amivantamab, the bispecific antibody targeting EGFR and MET, which we've used for a number of years now for patients with EGFR exon 20 insertions. Here it was combined with lazertinib, a third-generation EGFR inhibitor that I think we can think of as relatively similar to osimertinib. And when we looked at ami-laser, the combination arm here, versus osimertinib in that same frontline setting, again, a similar magnitude of benefit in this primary analysis, PFS by blinded review, 16.6 versus 23.7 months. Hazard ratio was 0.7. Again, similar story with the overall survival data. They are showing a trend towards improved overall survival here, but these analyses are not yet mature. So we actually just saw updated data presented by Shirish Gadgil at World Lung, which showed a hazard ratio of 0.77 at the second, I think, pre-specified interim overall survival analysis, but not quite yet reaching the threshold of significance. And then again, with amivantamab lazertinib, we have to be worried about toxicities. The toxicities of this regimen are significant, but different than I think what we see with chemotherapy. Here we see a lot of EGFR wild-type mediated toxicities, paronychia, rash, stomatitis. We do see some risk of thromboembolism with this particular amivantamab plus TKI combination. And then we also see infusion-related reactions, which can happen in up to about 2/3 of patients who receive IV amivantamab. I think we're really kind of in our clinical practice counseling patients that they're almost guaranteed to have some degree of infusion-related reaction. But importantly, it really only happens with that first day, and then they can continue to receive the drug without further issue. Again, if we look at the subgroups in the Mariposa study, I think that the overall message is the same, that a combination is better than OC monotherapy no matter what subgroup you look at. Interestingly, in this study, if you look at patients with baseline liver metastases, it was the hazard ratio was 0.58 for progression-free survival. Again, you can see that these patients did a little bit more poorly if you look at these absolute numbers, 11 versus 18.2 months. And then the patients without baseline liver metastases still benefit, but hazard ratio of 0.74. All of these have to be taken with the caveat of post-hoc subgroup analyses. Brain metastases once again showed benefit across the board. We saw patients benefit from ami-laser, whether they had baseline brain metastases or not, but I would say here we don't see that difference in the separation of the curves and the hazard ratio the way that we did with FLORA-2. I think we have learned from various settings now that amivantamab may have some intracranial activity. We saw an improvement intracranial PFS when ami was added to chemo in the later line setting, so perhaps it is also adding something in this context as well. One thing, just a quick word on subcutaneous amivantamab, which is coming, and we saw data, I think really intriguing data, in the refractory later line EGFR classical mutations presented at ASCO this year that showed that subcutaneous amivantamab combined with lazertinib was non-inferior to intravenous amivantamab. And in fact, if you look at the efficacy in that study, I think all of us were surprised actually to see a signal that perhaps there might be slightly better outcomes with sub-Q versus IV amivantamab. We actually actually saw an improvement in overall survival. I'm not sure we fully understand why that might be with just a different route of delivery, but certainly the efficacy is at least as good, if not better, with sub-Q amivantamab. And what we did clearly see is that subcutaneous amivantamab really improves the risk of infusion-related reactions. On the left, the tornado plot here shows all of the different IR-associated symptoms, and you can see that they're all very, very rare in patients treated with sub-Q amivantamab, shown in navy, compared to the IV form. But you just saw still this risk of VTE. It was actually a little bit lower. Again, I don't know that we know quite why that would be, but a little bit lower with sub-Q amivantamab. But nevertheless, there still is a VTE risk here. So important if you're using amivantamab with lazertinib to keep in mind that these patients need prophylactic anticoagulation for the first 4 months of treatment. The median time of onset of VTE is about 3 months, so you have to keep a close eye on them for that reason. So I think with that, we'll move back to our case and think through how we might apply our data.
Yeah, I think it's good to have these combinations. We're seeing a lot of questions come in virtually. When I think of Flora and osimertinib alone, there were so many things about that approach that I think we're very happy with.
Yeah.
Very quick onset, very well tolerated, CNS efficacy, something you could start right away with confidence, patients would feel better. And during the time you're taking a once-a-day pill, maybe you're only seeing your doctor 3 or 4 times a year. And so it really, I think, improves the quality of life and time outside the hospital. But our big knock against Flora was the PFS. And 18.9 months, really, we want longer periods of control. We have that with these combinations. But the trade-off is some of those things we loved about osimertinib alone go away, where now you need to come in for an infusion every 2 or 3 weeks, where now you're having a little bit more toxicity. And so really it's a question of are those sort of added benefits worth the cost, and is that justified? And there are some parts that we don't have yet. A few questions just to build on before we jump into this. Let me take one of these. Flora 2 showed excellent CNS data with the addition of chemotherapy. So does that mean the chemotherapy crosses the blood-brain barrier?
Yeah, I think it does. I mean, I think we've seen, particularly with pemetrexed-based regimens and in other contexts, we have seen that is a regimen that can have intracranial activity. So I think we are seeing that, with those deeper responses with more CRs, that there is an additive effect here of the two. So I do think that, chemo can work in the brain. It doesn't always, but it can.
And so if we come back to this case,
Yeah.
Zosia, let me just ask you. We have someone with liver metastases, bone metastases, multiple lymph nodes as well, and then 4 sub-centimeter brain mets. L858R, we know the prognosis is not quite as good for this mutation compared to DEL19. What would your regimen be today if you saw this person in clinic?
Yeah, I think that we've talked about this before. I think that my view on this has changed over the years plus since these data first came out. I think initially there was a lot of hesitance on all of our parts to really kind of jump into these combination regimens, worrying about the toxicity, worrying about whether patients would want to kind of take on these more complicated regimens. And I will say, I think these decisions are really different for different patients, and it really is a discussion with the patient. But I think I've started to lean more towards combination approaches, and the way that I've thought about it most is, it's not one risk factor or another. I don't think we can pinpoint one particular thing that says this patient needs chemo and this doesn't. But you can kind of take stock of the clinical situation and start to kind of add up the risk factors. So this patient has brain metastases, which is a big one for me. They have multiple sites of disease, a higher disease burden. They have an L858R mutation, which might, kind of portend a little bit of a more poor prognosis if we look at older data. We don't have, to Dr. Bond's earlier question, we don't have P53 status, but that's another one. And I think you kind of take stock and you say, how many of these does the patient have? Are they also then young and eligible for chemotherapy, which it seems that this patient is? So with that, I would favor a combination. And among the combinations, I've generally leaned more towards the chemotherapy-based approach, just based on the comfort that we all have with carboplatin pemetrexed, the kind of, I think, overall reasonable tolerance. And I would discuss that with the patient and see how she felt about it. But that's where I would lean. How about you?
I think that all of these are right answers.
Yeah.
And certainly I would not say that either Flora 2, Mariposa, Flora alone would be incorrect. But really, this is a long patient visit. Yeah. I do think that the exon 21, we know that we typically aren't looking at a PFS of 18.9. It's closer to 13 months. And so really is that 13 months on oral therapy alone, would we trade that for coming in with infusions and pushing that closer to 2 years? I think Flora 2 is a very appropriate regimen here. And I think that with the brain metastases and the L858R, I think that is probably one that I would introduce with some enthusiasm. But if the patient were opposed to infusions, if the patient really wanted to continue for whether it's employment reasons, whether it's family reasons, not come in for infusions, I don't think Flora is a wrong answer here either.
Yeah, I mean, 2 years ago, we would have given this patient osimertinib and not really worried too much about, whether that was the right or wrong answer. So I think it's important to keep that in mind.
Yeah. Well, let's jump back to our poll. Here's the QR code. If you want to key in again which regimen you would go for here, Flora 2, Flora. I'm not going to show these results afterwards, but I think that really there's multiple right answers here. If we made some variations to this case, so if we're thinking, all right, this is a good case for Flora 2, L858R, we can maybe push that PFS, rescue that from 13 closer to 2 years. The brain metastases, we see sort of exaggerated benefit with the addition of chemotherapy here. But what if this patient, instead of 61, were 85? And certainly we have 85-year-old patients who are diagnosed in our clinics all the time. Would that age push you in one direction versus another?
Yeah, it's a great question. I actually have a patient who's in his 80s, and we had this conversation not too long ago. And I think we always have to keep in mind that, it's not just the number, it's the overall kind of fitness level of that patient, their functional status, their overall health status, that is a factor, their preferences. But I would say that the older patients, we know that they do have more toxicities with chemotherapy, and I think with amivantamab as well. Combinations are tougher for those patients, and so that would make me probably feel a little bit more cautious about a combination-based regimen. I'll tell you, the patient that I had in clinic with this scenario came in and actually was really excited about chemotherapy. We actually, after some discussion, decided to just start with osimertinib and see how it went, and after a few weeks on osimertinib, he came back and he said, never mind, I'm good, I'm happy. So I think there's a big, part of discussing with the patient what's right for them. But I do think for the older patients, these combinations, they can have significant toxicities, and we have to be really, really careful about that.
I mean, to be clear, 85 is not an exclusion or contraindication to chemotherapy. And there's different types of 85. And you also have to look at, the support. Is someone on their own, very far away? Or are they close by? And I really think there are a lot of variables that go into it.
Renal function's another one in older patients with methotrexate that can come up a lot.
So we have to have a good creatinine clearance to consider chemotherapy. What if the other way? Instead of 61, what if they were someone that were 45, 40, in their 30s? We're seeing younger patients. We don't entirely understand why, but there is a younger population. And so if someone were much younger, would that push you in one direction versus another?
That's a great question. I think the kind of obvious answer is, well, yes, the patient's young and healthy. We should, try to be as aggressive as possible. But I think this can actually go either way. I think this is where a real careful conversation with the patient is really important, because you have some young patients who say, I'm young, I have maybe young children, I have a lot of things going on. I really want to do everything I can to give myself the longest time I can with this cancer. But on the converse, you have patients who say, I have a busy job, I have kids, I have, responsibilities. I don't really want to be in the cancer center. I want to live my life. I had this terrible diagnosis. I want to get back to living my life as normally as I can for as long as I can. And for that patient, deferring chemotherapy or a combination to a later line may also be appropriate. So again, I think this is a particular place where there's nuance to it. And certainly a lot of 45-year-olds, I think, are very good candidates for combination therapies. But I think that's not always the right answer for each patient.
It gets really complicated. At 45, we think we want to be more aggressive, but especially today, when we don't yet have a readout onto the impact on survival, especially in the U.S. where we practice, where health insurance is often linked to employment, maybe coming in every 2 weeks for an amivantamab infusion might lead to someone not being able to work, and then really that influences things quite significantly. So we think that every month is something that we would go for, but it's very individualized. If you remember when Professor Yilong Wu did a survey within China, and his survey was, if giving chemotherapy to TKI would increase PFS by 10 months, would you take it? And the majority of people would not. And these were people that most of them had already had TKI and chemotherapy. And so they knew what the experience was, and they said, that is not a trade that we're willing to make, that the juice wasn't worth the squeeze for them in that situation. And so I think it's very individualized, but we try to provide as much information as we can for the patients. This last one is also a practical thing, especially in some parts of the country. What if this person lives about 6 hours away from you? That's a real consideration, right?
Yeah, I mean, it happens to us on the East Coast, but I'm sure it happens even more in other parts of the country. It's a big one. I mean, I think, again, it's a practical consideration as to that might be someone where coming to clinic every 2 or 3 weeks is a lot to ask of them. I think there's also the safety considerations. We always tell patients who are getting the more kind of intensive the treatment regimen, the more potential risk there is that they call us and they're not feeling well. And then you say, okay, well, what I need to do is evaluate you in the clinic. is that going to be feasible when you live 6 hours away? You know, are you going to jump in your car if you're feeling poorly and you're neutropenic and you have a fever? How is that going to work? So I think those are the factors we have to consider. And again, this distance may be something that more pushes me in the favor of a monotherapy approach, particularly, for example, if it's an older patient, limited social supports or anything like that. But once again, it's not a black and white one, because some patients will say, it's fine, I'll drive, I can stay in a hotel. You know, it's not a clear cut either way, I think, for this one, as it is with all of these questions.
And when we think of things like these studies, can we look at quality of life information? They're going to be a little skewed, because someone that would never even consider combination therapy because of job, because of childcare, wouldn't enroll in that study. And so we'll never hear their voice from these trials. And so I think it's good to have these options. What we know today is that the combination therapies that are now approved give us the potential for a regimen that extends the PFS for a general population. I think what we're looking at over the next few years is sort of a rank and file, refining that delivery and really identifying where best to implement these advances. Let me go to this one question from the web, Zosia.
Yeah.
Do you think upfront SRS has a role in patients with brain metastases?
So I think that's a great question. I think that patients with baseline brain metastases, I think there's still certainly a role for involving radiation oncology up front for these patients and making those decisions in a multidisciplinary fashion. I think that's actually really important in this decision making. I would say that our threshold for radiation has gotten higher and higher, particularly with these more active, CNS active regimens, both because we want to avoid additional treatments that add toxicity in the short term, but the longer patients are living, you know, we have these patients who receive SRS and then later, a few years down the line, might be dealing with radiation necrosis. So I think kind of just doing radiation SRS to small metastases, if they're having a good response to systemic therapy, no. But there are certainly situations where patients might have more bulky metastases where we see some shrinkage, but maybe not enough that, you know, we really feel comfortable that this won't cause symptoms. Or, you know, patients, there are various factors, or maybe like an oligoprogression in the CNS. I think there's certainly still a role for SRS, but I think that, you know, the main take home is really we need to be talking carefully with our radiation oncologists. We need to make sure they understand is, you know, what do we expect from our systemic therapy? How likely, how hopeful are we that it's going to work, and make those decisions together in the clinic.
One last question about frontline therapy. Where does erlotinib, ramucirumab, and where do dacomitinib fit in? They seem to be recommendations in the NCCN guidelines. Zosia, do these have any role in your practice today?
Yeah, I think the short answer is they've really moved lower down. I have not been using these. I think that, you know, before we had these combinations, before we had osimertinib, we knew, again, same idea, combinations, later generations of TKIs were better than the first generation TKIs, but these combinations have, I think, significant toxicities, actually, whether you look at dacomitinib alone or erlotinib, ramucirumab. So I think it's really hard to imagine a scenario in which that would be my preferred approach. I mean, yeah. I don't know if you can think of one.
So dacomitinib is a drug that is approved. I think the only time I would use it is on a board exam. If we're asking for what's approved, I'm not sure that it plays a role today, just in terms of toxicity. In terms of erlotinib RAM, I've used it one time in the past 5 years, and it was someone that started with OC, but actually had a precipitous drop in ejection fraction.
Yeah.
And so we wanted to switch to a different TKI, and the RAM does improve the PFS, although the shortcoming, as we've mentioned, with erlotinib RAM, that study did include patients with brain metastases, very important.
And I think also important to say that this is different worldwide, right? So we're talking about our practice in the United States, but access to these therapies and combinations is not, you know, the same when if you look at various regions of the world. And so I think there are probably parts of the world where that's actually the best treatment option that's available. So great. All right. So should we move on to case 2?
Let's go to case 2.
All right. So a new patient here, a 58-year-old man with no history of smoking who noticed a non-productive cough. He initially kind of wrote it off, but the symptoms persisted. So he went to his primary care doctor and had a chest X-ray, which identified a left lung nodule. So then was referred for a CT scan of the chest, which confirmed a 3-centimeter pulmonary nodule in the left lower lobe. There were also enlarged mediastinal nodes and, unfortunately, multiple lytic bone lesions consistent with skeletal metastases. He then underwent a PET scan, which confirmed FDG uptake in these areas, but no other areas of FDG uptake, and brain MRI was performed and was negative. So he was referred for biopsy. In this case, it was an FNA of the lung lesion, which showed a TTF1 positive adenocarcinoma. And then biomarker testing was performed and showed an EGFR exon 21 L858R mutation and co-mutations in TP53 as well as TSG. He had a high PD-L1 PD-L1, so important to note here. This probably came back before the NGS testing might have come back, but appropriately in this case we waited for the NGS results to come back. So PD-L1 TPS 80%, L858R mutation in EGFR. Relatively well, 58-year-old man with a lung mass and bone metastases and nodal metastases, but no other areas of metastatic disease, and importantly, no brain metastases. So now this patient comes to your clinic to discuss first-line treatment options, and you sit down together and you go through the options. And we have the same options here, so we won't read through them, but let's take another vote. For a patient like this, what would be your preferred treatment plan?
So while we're coding in the voting, both online, Paul, you'd mentioned P53 up front. Maybe I'll put you on the spot. How are you approaching the P53 mutant?
So clearly people that are do worse, and clearly do worse. Does that tell you what the treatment you need? No. But certainly, the patient is more likely to pick an aggressive treatment if they have an aggressive disease. Once again, whether it should be chemotherapy or amivantamab remains to be determined, and certainly amivantamab will be much more attractive when it becomes sub-Q. So again, I would let the patient choose, but in this setting, probably OSI plus chemo would get more votes than not.
Let's see. Yeah. Indeed, it does seem to. It's interesting, a little bit of a different spread than with the first case that we saw. A little bit more enthusiasm for OC plus chemotherapy, 41%. About a third of people choosing amivantamab lazertinib in this case, and a little bit lower, 9% for OC monotherapy. A couple votes, some holdouts for erlotinib with a VEGF inhibitor, VEGF antibody, and as well as sounds like maybe one person voting for carbo-pembro, which I would say in this case is my least appealing of all these options, despite the high PD-L1 status, just to say that.
I think probably the wrong answer, frankly. I think that
Trying to be nice, but yes, clearly. All right, do you want to go through some of the data with the co-mutations?
Yeah, it doesn't surprise me. I mean, when we think of how we guide treatment, I think that we've moved further away from phenotypic classifications and are much more interested in hard genomic data. What mutations can we find that are going to tell us what the best treatment is? So it doesn't surprise me that people are a little more interested in using this to escalate therapy. But are the data there? And I think they're a little bit weaker than maybe we had hoped. As Dr. Bunn had mentioned, we know that when TP53 co-mutations are present, the prognosis is worse. This is pretty consistent through multiple driver types throughout lung cancer, but what we see is when P53 mutant is present at baseline, the PFS, the OS with standard therapies is worse. Now, the question is, can we intervene with that? And if we look at the data from Mariposa, they did show outcomes by P53 status. We see those two Kaplan-Meier curves on the right. When P53 is co-mutated on the top right, we see Ami laser clearly superior to osimertinib, there with a hazard ratio of 0.65. If we compare that to wild type, the wild type numbers are better, the prognosis is better, and Ami laser is still better than OC. The hazard ratio maybe not quite as strong there, 0.75. Ami laser is superior to OC with or without P53 co-mutations. The presence of that mutation largely prognostic, but not really guiding us towards a specific treatment. They do worse. All of them will do better with combination therapy, and similar things with FLAURA2. If we look at FLAURA2, mutant on the right, we see the outcomes are worse than wild type on the left. OC chemo has better outcomes here. That hazard ratio perhaps a bit stronger, 0.57 when P53 is mutated at the present. But again, not really telling us whether we should or should not, just sort of showing us that these patients are going to do a little bit worse. What about ctDNA? This is a tool that's rapidly establishing a presence in our clinics. There are different ways we can use circulating tumor DNA to guide our therapy. One, is it detectable? Is EGFR mutation detectable at baseline? And two, does it go away with therapy? Sort of at baseline, does it help guide treatment? Or during treatment, is it a pharmacodynamic marker that maybe tells us if we're on the right track or not? What we see here with Mariposa, with amivantamab and lazertinib, is whether ctDNA is detectable or not, Amilaz clearly superior to OC. When ctDNA is present, the hazard ratio 0.68. When ctDNA is not detectable, hazard ratio 0.72. We see a benefit to the combo in either case. The overall numbers for median PFS are worse when ctDNA is present. But again, the outcomes are better with combination therapy. Now, what if you clear ctDNA? Well, if you clear the ctDNA, which is at the bottom right there, when you clear ctDNA, that Emi-Laz combination is still superior at 0.64. If you don't clear, the Emi-Laz hazard ratio is a little better, 0.49, but the outcomes overall are much worse. And so I think one open question that we have, Zosia, is if we start on that gray line without cleared ctDNA, could we then escalate therapy to combination and then push people over to that blue line? And we don't know the answer to that yet, but one of our colleagues is looking at a similar approach in that CT Shedder's design, although that's more focused on a FLAURA2 approach. When we look at the FLAURA2 data with ctDNA, when baseline EGFR is present, OC chemo is better than OC, hazard ratio 0.60, clear separation of these curves. When it is not detected, the prognosis overall is better, and here, that separation is not so clear, hazard ratio 0.93. So really, the FLAURA2 data for ctDNA seems to be strongest when we detect EGFR mutation in the blood. When it's not detectable, the outcomes are better, and maybe the benefit of adding chemo there is not quite as strong. On clearance, again, seems to be prognostic, but not predictive. So we know that when we don't clear that ctDNA, the prognosis is worse. The open question we have is, can we do something about it at that time to sort of rescue patients, to improve prognosis? Is there some dynamic marker? And Dr. Helena, you at Memorial Sloan Kettering is looking at that approach where if we see those poor prognosis features, we can make some change. You're involved in that study, right?
Yeah, I think it's a great question. I think one important point when we look at these ctDNA data from these studies is, when we do ctDNA testing in our clinic, we're often using one of the tests like Guardant Foundation. There's a number of them. In these studies, they used, at least I know for a fact in FLAURA2, they used a ddPCR-based assay, which is a little bit more of a sensitive assay, and it's a little bit probably of an apples to oranges comparison to think about how that applies to our ctDNA that we're using the Guardant or Foundation NGS-based assays in the clinic. We know that ddPCR is a lot more of a sensitive assay. Now, Dr. Yu's study that we have open at MGH is trying to get at this question by starting patients on osimertinib, and after 3 weeks, actually a Guardant is sent, and then if those patients have any detectable ctDNA on that Guardant assay, it's not really clearance in that instance, just for practical reasons, just is it detectable or not, those patients are being randomized. And I think it's an important question, and I think it really gets at this whole idea that we've been talking about this whole morning, which is how do we identify the patients that really need these combinations? I think what we're seeing from all these data is, we can look at all these different subsets and try to put this together, but we don't really know exactly when we see a patient, like what is the profile of patient where chemotherapy is the best fit? What is the profile of patient where amivantamab is the best fit? And I think that's really the data that we need to work together from these studies going forward so that these discussions are a little bit more clear-cut and there is more of a sense of what the right answer is.
I think that's what we were hoping for with these, especially with the genomic data. We were looking for some test that said, okay, this should get amivantamab lazertinib, this mutation should really get chemotherapy, and we didn't see that. We see the combinations are consistently providing longer PFS, but don't really help us deliver those treatments to specific patient groups.
And the mechanism of action of these are so different that you'd think there really would be differences, biologic differences in cancers that would benefit from one or the other. But stay tuned, we don't have that data yet. But let's come back to our case. So again, 58-year-old healthy gentleman, no smoking history, has a 3-centimeter lung mass, nodal metastases and multiple lytic bone metastases, node brain metastases, and then was found to have an L858R mutation with P53 and TSG co-mutations and a high PD-L1. So Stephen, we're going to put you on the spot here. This is a patient you saw in clinic last week. What treatment would you discuss or recommend to this patient?
So I think the approach today, the frontline visit, as you mentioned, is a lot longer of a visit. We go through the different options that are available, the relative merits, but it's our responsibility to make some recommendation than to get input from the patients. And I think a recommendation here with P53, with the L858R mutation, with bone metastases, I think the FLAURA2 combination makes a lot of sense here. And I think this is one that would be a great starting point. But again, if the patient said there were specific circumstances really wanting us to avoid IV therapy, I think osimertinib alone is still a reasonable choice. It's how we've treated things for years, but what I'd probably reach for first would be FLAURA2 here.
Yeah, I agree. I think, I want to go back. I didn't want to. So I agree. I think that all of these are reasonable options, and it is a long discussion with patients. And I've been humbled and surprised actually by the strong opinions patients have on this in any direction. You might look at a patient and say, oh, this is a patient that's probably going to be, happy to take osimertinib monotherapy, and they say, and then the converse. So I think it really is important to try to present this data, and it's not easy, it's complicated data, but try to present it in a way that allows that patient to help make an informed decision that's right for them. I think that in terms of questions that we're getting, I think the two big themes that we're seeing, and I think we've already covered this. One is the challenge of knowing how do you pick between FLAURA2 and Mariposa. These are both positive studies. Really, if we look at the outcomes, they're quite comparable between the two, but they have different safety profiles. How do you think about that? How do you talk about that with patients? Are there, kind of factors that make you lean in one direction or another?
Well, there are. I think that when we think of FLAURA2, it's mostly dermatologic, and so it's not as much the cytopenias, the nausea, vomiting I see with chemotherapy. It's more dermatologic, which could be very important, and paronychia, which is important. So here, there are potentially certain aspects of a patient's life. If you had a professional pianist, well, maybe the paronychia is going to be a real problem in their quality of life. And so maybe this is a regimen where chemotherapy is a little bit more appealing. If you've got someone, starting off with very low blood counts and cytopenias for whatever reason, well, then maybe we want to avoid those with chemotherapy, and Mariposa makes a little bit more sense. And so I think that we have to tailor it to each individual circumstance. It doesn't lend itself well to flowcharts.
Yeah, and I think another question that was asked in a couple of different ways in the chat is how does the thinking about what options might be available to that patient in later lines of therapy impact your decision making in that front line?
Yeah, so this is I think really important. I think Dr. Carbone submitted a comment here that really says, and I'll just sort of read this. We need to move away from being happy with PFS endpoints in EGFR mutant lung cancer. The problem with frontline studies is they don't take into account the very positive Mariposa 2 and ADC studies second line. Should we be saving more toxic and more onerous combinations for second line? And this is really the problem. When we look at PFS, that's not really the only endpoint that matters in practice. It's important for the study, but the question we have when we look at OC chemo, for example, it's not osimertinib versus osimertinib plus chemo. It's osimertinib then chemo versus osimertinib chemotherapy up front. And that we would call a PFS2, but the study wasn't really designed to ask that specific question. So those data are a little bit difficult to interpret. And we have good options in the second line. The Mariposa 2 regimen Dr. Carbone is referencing is chemotherapy plus amivantamab. And when compared to chemotherapy, profoundly increased response rates, progression-free survival at the cost of some toxicity. But here we saw much better outcomes. So would someone be better served with osimertinib alone and then Mariposa 2 versus starting with Mariposa? And I think those are complex questions that we probably won't see answered in a prospective way. But I do think that second line option really is important, and that's why survival, I think, is an important endpoint. If patients are going to live exactly the same amount of time, are we just increasing the time on IV therapy? I don't think that's a good outcome. So I think that there's a lot of room for discussion. The better options we have in later lines, maybe this is a good opportunity to maximize the quality of life on just a once-a-day pill, really supporting the use of osimertinib. So I think that's pretty reasonable. One of these questions I have, and I'm interested in your practice, is if you started with OC alone and then moved to chemotherapy, would you continue the osimertinib in that setting, assuming we weren't giving Mariposa 2?
Yeah, so this is a question that again is evolving, and it's a really important one. I think both you and I know we did this for a long time. So patients who were on osimertinib, I would say particularly patients who had brain metastases initially at diagnosis that responded well to osimertinib, then they have maybe systemic progression but no CNS progression. We all felt very comfortable, in a relatively data-free zone. There's a prospective study called Compel that has looked at this but hasn't read out yet, but saying, well, let's add chemotherapy to the osimertinib, maintain that for a CNS control. And I think it's become a more complicated question now with Mariposa 2, because really we can take that approach, or we can say we're going to take a different approach and drop the TKI and move to Mariposa 2, to chemotherapy with amivantamab. And this is, again, a conversation I'm having with patients. I will say I feel a little bit nervous about stopping the TKI in those patients with brain metastases have been really, really stable. But the data from Mariposa 2 did show that intracranial PFS was better with chemo plus amivantamab versus chemo alone, suggesting that the amivantamab is working in the brain. So, I think that it's still an okay decision for some patients to add chemotherapy to TKI, but certainly I think, Mariposa 2 has a lot of appeal, as you kind of highlighted as well, and I think these are individualized decisions. I think the challenge, also if we look ahead, if we're talking about using FLAURA2 for several of these patients and we give them the TKI with chemotherapy up front, and then they progress on that regimen, what's next? Then it's actually a challenging question, because we know that amivantamab may be active for these patients, but we don't have an approval for amivantamab outside of that first line, amivantamab lazertinib, or in the second line with chemotherapy. So how do you approach that situation?
Yeah, so Naman asked this specific question, and so, I think part of it depends. If we look at the FLAURA2 data, most patients didn't continue the pemetrexed indefinitely. If we look at the median number, it was closer to 8 cycles or so. And so if you had started on FLAURA2 and then stopped the chemotherapy along the way for toxicity, I think that we look at that period off chemotherapy, maybe that influences it. I think it's hard to justify continuing or reintroducing carboplatin pemetrexed if someone progresses while receiving pemetrexed. That seems like a lot of toxicity for not a lot of efficacy. And so in those settings, could we try to get amivantamab off-label based on the Chrysalis data? But hopefully in the near future, we'll have other options, like ADCs, and there have been a lot of questions about where ADCs will fit, and I think they will have a big role. There are 2 in this space that we're looking forward to, patritumab deruxtecan, or HER3 DXd, and datopotamab deruxtecan, or Dato-DXd, both with profound activity, high response rates in EGFR mutant lung cancer, and I think are destined to play a role. How we sequence those with everything is sort of another complex question. But maybe we'll ask for people to re-vote on their role of treatment. Again, the key here, this was an L858R, bone metastases, no brain, but we did see a TP53 co-mutation. What would your frontline option be in this setting?
It won't be shown. Maybe while we're waiting for people to vote, we can answer this question, which is our opinion about resistance emerging versus various resistance mechanisms like C797S. I think, I will still put in a plug. I think doing, repeat testing at the time of progression on any of these regimens, I think still is important. We can sometimes find, alterations or changes that can impact our treatment. So
do you always rebiopsy at the time of progression?
Well, I have certainly on TKI monotherapy, and I think I will continue to do so on TKI plus chemo and Mariposa. I think there's a few things that are really important to find. Histologic transformation being the main one that a tissue biopsy can identify. We don't know how likely these will be after FLAURA2 or Mariposa, but certainly we do know that they can arise, and depending on the series, 10 to 15% of patients on TKI monotherapy, and have important implications for prognosis and for chemotherapy selection for these patients. And then sometimes you can find things like a C797S resistance mutation or MET amplification, where largely clinical trials, but there are options for treatment targeted at those. We saw actually intriguing data from the Mariposa study showing that, maybe not surprisingly, but both MET-mediated and secondary EGFR resistance mutations were lower in the patients treated with amivantamab lazertinib, which is not unexpected given the mechanism of action of amivantamab. So I think this landscape will change, but I do still think that there's a role for looking for resistance mechanisms in the hopes basically of really exploring all the therapeutic options that we might have for each patient.
Yeah, I think that we always rebiopsy, looking for histologic transformation, looking for isolated clones that might not show up in the blood. But as I say that, I'm reminded of a study, the Elios trial. In this study, this is a study where patients received osimertinib, and the whole purpose of the study was to get a biopsy before and a biopsy at progression, just matched biopsies. And so you have this population of people that agree to biopsies after. The biopsies are paid for. It's at centers that can do biopsies well with academic interest. And in these completely unrealistic, perfect conditions, the rate of paired biopsy was 40%. Yeah. And so I feel like that's the ceiling. And so when someone says, we always rebiopsy, clearly that's not the case.
Absolutely.
You always can't. I think we'll always do liquid. We try to do tissue, but the reality is sometimes we can't or just aren't really safely able to do that. I do think C797 is interesting because when we saw this mutation, the nice thing about this C797S, we thought this was going to be like the T790. We thought it was going to be more common. It's pretty rare. We know that the first-gen TKIs don't bind at that site. They aren't affected by it. So we could go back to gefitinib or erlotinib or combine the two, which is work that I know you're involved with. So we had therapeutic options and newer drugs. But the problem that we saw, tell me if this is your experience, is when we saw C797S, we would give a first-gen TKI, we would see a response, but it would be so transient. That it just wouldn't last. It was the initial response, and then we're right back where we were a few months later. And I think the challenge is that after osimertinib, resistance is very often polyclonal, where we'll see that C797S, we hone in on that, but there's all this other stuff going. So we can target that clone, but if that's not the only clone, you're only treating part of the problem. Now, one of the things about Mariposa is we did see maybe a little bit less polyclonality, hard to know, but does C797S mean something different after Flora 2 or after Mariposa? I think it's going to get very complicated, but we don't know that yet because most of the resistance we're seeing is the early resistance. We don't know anything about the late resistance yet. Right?
And we know that there's differences in those patterns in the late progressors versus the early. Do you want to cover these questions real quick? Or?
Yeah, so what if ctDNA was detectable at baseline and cleared in patients that clear? We did see sort of better prognosis. If it's detectable, we still saw pretty strong benefit of Flora 2, so I still think I'm in that setting. If it was not detectable at baseline, the Flora 2 data in that setting weren't so strong. Does that influence your practice at all?
I think it goes into the kind of category of good versus bad prognostic factors. And, a lack of detectable ctDNA at baseline would go into the category of good prognostic factors, along with a lack of brain metastases and lower disease burden, and might push me more in the direction of monotherapy. I will say I think it's important to note that we're not routinely checking for clearance of ctDNA on treatment as a part of routine clinical practice. As I mentioned, we do it in the context of clinical trials, but I think we probably don't have enough data yet to advocate that be done as part of routine practice until we really learn more about what that should mean for how we change therapy based on those results.
It's not standard. There's something appealing to it though, right? To start with osimertinib, you check, and if you're not clear in your senses that we're not on the right curve, but then the question is, can we get to the right curve, or is that just the curve with this disease? And so does changing the chemotherapy improve outcomes, or does it just make us feel like we're doing something? And that's why I think these studies are helpful.
That's why you should refer all your patients for the Shutter study.
That's right, exactly right. So last case here, case 3, 63-year-old man, no history of smoking, incidentally found to have lung nodules on x-ray. Here at the Matos meeting, we talked about incidental lung nodules today. This is a case where we saw bilateral lung nodules, but nothing else. MRI of the brain showed no metastases, biopsy, adenocarcinoma, and here's an EGFR exon 19 deletion. So deletion 19, lung-only disease. Paul, we're going to say P53 wild type for this one. Comes to the clinic to discuss frontline treatment options. What are we choosing here? Osimertinib alone, osimertinib plus chemo, amivantamab plus lazertinib, erlotinib, ram, or bev, carbo-pem-pembro. And that last one is the wrong answer. Zosia, while we're voting on this, and you can scan this QR code to key in at home, you can vote on that polling panel. There's a little bit of data here. Let me knock some of these out because there are big gaps in data. One, a question of does adding metformin to TKI inhibitors improve outcomes? Very mixed data. I think that's not really standard right now. Zosia?
Agree. A lot of patients actually, I would say, ask this question and say, should I take metformin? We have to keep in mind metformin has side effects, GI side effects in particular. The data is mixed, and I would say not definitive about any clear benefits, so I would not recommend that.
The in vitro data, the preclinical laboratory data showing the metformin's effect on lung cancer are doses that we can't give to actual patients, and so it's a little hard to interpret those data. My concern here and why I would discourage starting this if you weren't already on it is if you start metformin, have severe diarrhea, is that from the metformin or from the osimertinib? Does it lead to inappropriate dose reductions and dose holds? Does it get in the way of the treatments that we know provide benefits? So I think not standard. Tumor treating fields, we know this is a new therapeutic strategy. Is there data for synergy between this and EGFR TKIs? Not to my knowledge, but certainly willing to hear more information about that as it continues to emerge. We talked about some of these clonal mutations. And then what testing approach do you use for co-mutations? I assume you're using NGS?
Yes, I think NGS is the clear right answer here. A multi-gene NGS panel, whether a send out or whether you have one in-house. I think, the more genes covered, the more information you can get. And I will say, for my newly diagnosed patients, I actually order the tissue testing and will order a liquid biopsy on the day I meet them to try to really cover all the bases and get as much data as I can as quickly as possible.
So our voting poll here, pretty clearly this was the strongest case for osimertinib monotherapy. The majority of people voting for that. I think a very reasonable option. If there's a case for OC, you've got a DEL19, lung only, incidentally noted, so no symptoms. If someone's asymptomatic, you cannot make them feel better. You can only make them feel worse. And so I think this is a case where osimertinib makes a lot of sense, though, again, combination therapy here, maybe not something we reach for right away, but not wrong. It is an FDA-approved treatment. What's your approach here?
I fully agree, but I think to change the question a little bit, if we fast forward, a year or two from now, and if there's a survival benefit to FLAURA2 or MARIPOSA, would that change the thinking? Perhaps slightly. I think it's still very reasonable, but I think a survival benefit does drive decisions. As I think Dr. Carbone put in one of the questions, it really has been our gold standard, and if we're seeing patients living longer, and it's a patient who's eligible for a combination, that might change my thinking down the road.
When the survival data do come out, one of the big flaws anticipating it is that we didn't really have full crossover, that the study wasn't designed to have guaranteed crossover, whether it's the chemotherapy or whether it's amivantamab in the second-line setting. And so without full crossover, is the OS real or is it artificial? And I totally understand all those. It's hard to dismiss an OS endpoint, though.
And I think particularly for a chemotherapy combination, where we do know that many patients do have access to it. It's not really a question of could they get amivantamab if it wasn't approved or things like that. So I think for the chemo combination, really, if we see a survival benefit, it tells us that there's a magic to giving those two kind of therapies first. Going back to that kind of old adage of give your best therapy up front, because you don't know whether patients will make it to that later line therapy.
This is a good question here, a provocative question, Zosia. Do you think there'll be a point where we can stop TKIs in patients with driver mutations who've been on it for over 5 years, the way we sometimes stop immunotherapy? I guess another way to ask this, do you think we can cure people with TKIs?
I think it's a provocative question, and I really wish the answer was yes, but in my heart, I worry that, TKIs are not curing patients. And so we all have these patients that we've had in clinic who've been on them for 8 years and 10 years, and, they say, do I really have to take this forever? And I think, it's a data-free zone. We don't know, but we've also had cases of patients who progress even at those time points. And so to me, I would personally worry. There have been cases where, for whatever reason, the patients have had to come off for toxicity. And sometimes we've seen, that they can stay off treatment and do okay after that. But I think the challenge is that this is a really hard question to answer in clinical trials. How do you select that patient population? What is the endpoint? What is the follow-up? This is probably something we'll never have data to really tell us what to do unless we can really study those long-term survivors and identify some sort of molecular characteristics that are different. But I think for now, this is very different than immunotherapy, and we have to think about these drugs differently. What do you think?
I think an important point, I can read faces, George Simon completely agrees, we shouldn't be stopping our TKIs here. But I think an important point for some of the patients following along, or patient advocates, is that when we see a complete response, no disease for years, it's because of this drug. Yeah. And right now, in the absence of toxicity, we would not recommend stopping it. But could there be a future where we'll find some way to stop therapy? I don't think it'll be just TKI alone, but if there's some magic combination, I think that's what we're striving for. But we are definitely not there yet. If there's any questions in the room, we're happy to have a discussion and put a summary of some of the key trials up here. It's nice to have these different options. We just have a minute or two if there's any questions in the room. There's a question here. What pemetrexed-free period would you consider before revisiting chemotherapy and amivantamab in MARIPOSA-2? What would your answer for that be, Zosia?
Yeah, I don't know if I have an exact number in my head. I think the longer the better. I think that if patients have been off certainly for a year or more, I would probably feel, okay about going back, especially if they did well on the therapy. Shorter than that, I worry that the benefit may be less, but I think, really it's the patients who stopped chemotherapy and hopefully have been, off of it for many months or maybe even into years where I would reach back for it.
Yeah, my number is 6 months exactly.
All right, there you go.
There's not an exact
Straight
number.
from Dr. Liu, there's your answer for today.
Let me ask Corey, though. I know, Corey, you talked in the past about platinum re-challenge. Do you routinely re-challenge with platinum today?
We have a study where we're doing that, accruing terribly slowly. But I would consider it. I mean, we do it in small cell. We do it in ovarian. We've never really done it too much in lung. There's only one trial that I'm aware of. I think from France, a randomized phase 2, and they did have, surprisingly, a PFS benefit, but the numbers were inadequate to really look at a survival difference. I do it. If somebody's been off treatment, I'd much rather give them a PEM-carbo regimen, maybe with Bev, than, God forbid, challenge them with docetaxel and ramucirumab. So, but I actually have a question for both of you, and maybe for others in the room. Let's assume both FLAURA2 and MARIPOSA are going to show an OS benefit. They sort of both are heading in that direction. The hazard ratios are under 0.8. With the onset of the sub-Q formulation, I mean, right now, if I've given in combination, it's strictly been FLAURA2. Do you think there would be more uptake, and do you think there'd be any advantage in that setting? And again, you have the option of giving chemo later, which you wouldn't necessarily do with FLAURA2.
For me, the subcutaneous formulation, clearly you're eliminating the concerning infusion reactions. You're cutting down on time a lot, and maybe there's more of an efficacy advantage, but it doesn't really seem to impact some of the other toxicities, which I think are the ones that get in the way. Dermatologic toxicities, the paronychia, the scalp rash, those sorts of things. And so because of the potential survival advantage there, I think it pushes it a little. Where I think it makes a bigger difference, though, Corey, when we think of these infusions, it's allowing a lot of travel time, it's handcuffing patients. Is there a future where we can push amivantamab out to patients? If it's subcutaneous, can we send it to patients where they're not coming in, where we're doing it remotely, where patients are getting therapy through a home infusion nurse that's delivering a sub-Q treatment? I think that's potentially a future that I think is pretty appealing, especially if you're going to stay on this drug for years. But to me, I think that the same questions remain, whether it's sub-Q or IV.
Yeah, to me, it's really the long-term chronic dermatologic toxicities that my patients have struggled with when they've had them, the scalp rash, the paronychia, those things. And those are, even with home infusions, you still need to be seeing those patients and managing. So I think what we really need is to understand which patients, really benefit from that combination.
We have some new novel approaches under investigation that are hoping to change the practice further, including incorporation of antibody-drug conjugates. But really, I think we both agree with osimertinib in this setting. We're going to skip through these. If this was L858R, I think still a reasonable option, really if there's low-burden disease, no symptoms. We have some final follow-up polls. We're right at the end of time for this session. I think the bottom line here is we have combination therapies that prolong PFS, that can lead to better outcomes. It's important we have our eyes wide open about the costs that are associated with that, primarily in terms of toxicity and infusions, but these are exciting new options for our patients that can provide longer-term outcomes. So thanks for joining us, both in the room and at home. You can visit us at peerview.com/Lake Tahoe 24 for evaluation, for your CME credits, to download these slides and to watch the replay over the next 24 hours. Thanks a lot, everybody.
And thanks for the great questions.